Okay, good morning, everyone. Welcome to Healthy at Home. My name is Dr. Melanie Carminati, and I'm the founder of Inspira Physical Therapy and Pilates. Today, I will be speaking about osteoporosis, more specifically, safe exercises for osteoporosis. Earlier this week, I spoke with one of my colleagues, Dr. Rubinova, who's an endocrinologist, and we chatted about osteoporosis medications and nutrition, but today we'll be getting more into depth about exercise. So I'm gonna share my screen so you can see the PowerPoint. Okay. All right, and let me just start this. Okay, so hopefully everyone can see that. So already said, today's topic is safe exercise for osteoporosis. As a disclaimer, this is an educational virtual video chat. This is not physical therapy. If you are in need of one-on-one skilled PT, you can contact myself and my team at hello@inspirapt.com or call or text that number there. Today's agenda, we're going to start off detailing osteoporosis pathology, modifiable and non-modifiable risk factors. I'll explain bone remodeling and Wolfs Law. I'll discuss the National Osteoporosis, Foundation's recommendations for management and prevention of osteoporosis. I'll discuss the movement contraindications and precautions if you have osteoporosis. And then we'll get into safe exercises and why seeing a physical therapist is important. So to start, what is osteoporosis? So how I like to describe osteoporosis is that it is a metabolic disease with endocrine and physiological influence. So the whole endocrine side of things, I spoke with my endocrinologist colleague earlier this week, and today we're going to speak more about the physiological influence. Good morning, Jeannie. Thanks for joining. And so there are 3 types of osteoporosis. The most common type is type 1, that is experienced in postmenopausal women due to the decreased estrogen production. Type 2 is just based on aging, not necessarily by the hormonal influence from estrogen, and it is seen in individuals after the age of 75. It's seen in both men and women, however, it is seen twice as more prevalent in females. Then there is the secondary form of osteoporosis, which individuals who have Crohn's disease, different eating disorders, who are using prednisone, who may be on different chemotherapy medications can experience. And that is because those eating disorders, gastrointestinal disorders, and those medications are taking out the nutrients in your body, in the blood flow that the bone needs to stay healthy and to stay dense. So osteoporosis risk factors. There are non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors are if you are older than 50. Obviously, you can't change that. You also can't change your ancestry and your descent. So if you are Caucasian, Asian, or of Northern European descent, it is a risk factor. You're more likely to develop osteoporosis. If you have gone through menopause, another thing can't change. Family history, so if your parents, grandparents had osteoporosis, it is another risk factor. One thing is long periods of inactivity or immobilization. Now this is in non-modifiable, but I should have put a caveat in there. That's for individuals who have had spinal cord injuries, who necessarily can't do the weight bearing as regularly. So to a degree, it's not modifiable for them. And then femoral neck bone mineral density. Sometimes our bone mineral density is just at a certain level, a baseline. Once you reach a certain age, your bone mineral density reaches its peak. And once it reaches peak and you've gotten older, you obviously aren't able to go back in time and change it. So the modifiable risk factors, that's what we really want to focus on. Physical inactivity. You can become more active. tobacco, alcohol. So if you cut out these things, it helps with the bone mineral density. Medications, which was discussed in depth on Tuesday with Dr. Rubinova. Depression, so that would be something that would be modified via psychotherapy and medications as well. Diet and nutrition, we spoke about in depth on Tuesday. Again, you need to be having the calcium, the magnesium, and having those nutrients in your body, in your diet are really important. If you're not able to have those nutrients such as calcium and magnesium in your diet via food, then that's where supplements would come in. Weight and BMI is something that is modifiable as well. So associated conditions, we spoke briefly about this in the secondary type of osteoporosis. If someone has an endocrine disorder, eating disorder, I mentioned spinal cord injury, if they had a stroke, if they have undergone cancer treatment. So these individuals, we will see osteoporosis for the nutrition side for the first two, because they're not having those proper nutrients that are being absorbed, right? So there's that malabsorption with the eating disorders and the endocrine disorders. And then as well as for the cancer treatment, for the spinal cord injuries and for individuals who have had strokes, which is cerebral vascular accident, they're not getting enough weight bearing, and they're not getting enough muscle activity as someone who wouldn't have had a stroke or a spinal cord injury. So clinical manifestations. So the thing about osteoporosis is it's silent. There are no symptoms. You don't wake up in the morning one day and say, you know what, I feel like I have osteoporosis. It just doesn't happen. So, however, what happens with osteoporosis is that it puts individuals at an increased fracture risk. And some of the clinical manifestations that you can see is that there is a loss of height. You also see postural changes. So the rounded posturing, the abdomen becomes more protuberant, forward head, that kyphosis, which is what we call the curvature in this direction in that mid-back, dowager's hump, and then the loss of the normal curve in your lumbar spine. So these are things that we can see that will lead us to believe, you know, this person appears as though they should have a bone density test, bone density scan, because it's likely. Some things that happen when your posture is modified, you can have excess stress placed on the back musculature, which from these postural abnormalities. In addition, the areas in which the fractures can happen, I should have listed wrist there too, so let's add wrist to that list. Wrists, hips, ribs, the radius, and the femurs. So those are the more common areas for fractures. So that's something clinically, if someone is seeing fractures in these areas and someone is within a certain age group and has some of those other demographics, then they would look into the bone mineral density and see if they in fact do have the decreased density. So some bone terminology. I've been speaking mainly about osteoporosis, but osteopenia is the precursor. So that's when there's too little bone and low bone mass. There's also something even before that called osteomalacia, which is just softening of the bones. Now there is a flip side of osteoporosis, and that's osteopetrosis, which is when you actually have increased bone density. So that's less common, but it does happen. And I have had some patients who actually had increased bone density. So bone 101, time for some physiology with Melanie. So we are gonna go into the bone basics. Osteocytes and osteoblasts, those are the two bone building cells. The osteoclasts, should I say, the osteoclasts are the bone cells that actually break down existing bone. The osteoblasts, they build up the bone. So they're bringing more minerals to the bone to help keep that bone nice and strong. And the amazing thing about bone is that it's not this solid, like unchangeable structure. It's constantly undergoing this bone remodeling cycle because it's active, it's healthy, it's living tissue. So the osteoblasts and the osteoclast cells are balancing out each other, trying to maintain this equilibrium for bone density. So purpose of remodeling. So I already said, to maintain the equilibrium. The whole goal, and this happens on a cellular level throughout our entire body, is we're getting rid of the waste, bringing in new minerals to keep the bone healthy. And then the osteoclasts that are getting rid of the waste and the damaged bone, they're doing that to help and maintain the homeostasis. Now, I mentioned calcium, and I just want to have a few notes about calcium for you all, about why calcium is so important. On a physiological level, calcium actually helps to regulate your heart rate, helps to regulate muscle contractions, blood pressure, and other systemic functions. So when your blood calcium levels drop, the needed calcium is retrieved from the bone bank. So moving on to, what does this mean for us? Wolf's Law. Wolf's Law is a physics law that states that when bone is laid down in areas of high, or that bone is laid down in areas of high stress and reabsorbed in areas of low stress. So this means for us that more physical activity leads to more bone being laid down, which is really cool. We can influence our bone density by being more physically active. The National Osteoporosis Foundation has recommendations for managing and preventing osteoporosis. The first is to have a daily walking program. The second is to have resistance training involving springs, bands, weights. The third, an extension-based exercise program, which extension is back bending. Remember, we spoke about the clinical manifestations being the rounding, that thoracic kyphosis or dowager's hump. You want to be doing the opposite because of the tendency to move into that forward posturing. And then also balance training. Balance training is important for fall prevention. Now, movement contraindications. So far we've spoken about the basics of osteoporosis, the different types of osteoporosis. We've spoken about the osteoblasts and osteoclast cells. We just spoke about Wolf's Law and what that means for us. Wolf's Law allows us to influence the bone by putting excess stress on the bone. I'm going to get into later how you can put excess stress on the bone. But I want to first just say that there are some movements that should be avoided if you have osteoporosis. Now, flexion. So flexion is forward bending, especially repetitive, that needs to be avoided, such as with crunches. So that puts a lot of compressive force on the spine, and that will increase the likelihood of fractures. Another is end range side bending, okay? And then end range rotation. So it's not just bending at all, it's getting to that end range and really putting pressure on the spine there. So those are the three movement contraindications that should be avoided if you have high risk of fracture with osteoporosis. Now, I should say that I have worked with individuals who have osteoporosis. Osteoporosis can be present in your spine, it can be present in your femur, it can be present in your wrists. So these contraindications that I'm mentioning are for the spine because that tends to be a more common area for the osteoporosis presentation. In addition, any combination of these three motions should be avoided as well. So some combinations are the saw exercise in Pilates and the crisscross. Those combined flexion, rotation, and a little bit of side bending actually, and it just adds a little bit extra pressure on the spine. So safe Pilates exercises. What is safe if you have spinal osteoporosis? neutral spine exercises. So that's aligning the cervical, thoracic, and lumbar portions of your spine and keeping everything aligned so that there is no excess stress being placed on any part of the body. I have an image for that in just a moment. Spinal extension exercises, which we've already spoken about, backward. And then quadruped exercises. That's on all fours or on your hands and knees. Neutral spine. So you can just see here the cervical, thoracic, and lumbar. There are curves in them, but they're aligned in the ideal alignment. So why seeing a physical therapist with osteoporosis training is important. So Dr. Urbanova, the endocrinologist who I just spoke with on Tuesday, said this, that it's not just seeing any physical therapist or referring to any physical therapist, but she'll refer to a physical therapist who is educated about osteoporosis, knows the movement contraindications, and knows how to make modifications. So if you are someone who has osteoporosis or osteopenia, you want to work with someone who is educated about what needs to be done to increase the bone density and what needs to be done to reduce fracture risk. So what I do with individuals who have osteoporosis, I do neutral spine education, core awareness, as well as strengthening. Postural education is huge, balance training, safe progressive resistance training, right? Because you don't just want to pick up 100 pounds and try to do a bicep curl. That may do more harm than good. You want everything to be progressive. Movement contraindications are communicated and are educated, and the client or patient should understand them. And then a physical therapist is tailoring a therapeutic exercise program for that individual. And if they are also a Pilates practitioner like myself, they're able to include Pilates Rehab exercises. And I think the biggest thing why working with a physical therapist is beneficial is the exercise rationale. So they'll know what exercise to start with and how to progress. So I'm going to stop my screen share now and just do a demo of some very foundational exercises for osteoporosis for the first stage. So just give me a moment to get myself onto the mat and then we'll get into it. Okay. Can you guys still see me?
Yes.
Yep. Okay. Let me just make sure the angle's okay. A little bit down. Good. Okay. All righty. So we spoke about posture and that neutral spine alignment. So that's something that is really challenging to learn in the beginning. But once you know it, it's a really good home base. It's a good place to come back to. And it's especially important for osteoporosis. So one of the first things that I do is go through basic breathing exercises and pelvic tilts. Some of the cues that I will give are helpful for finding that neutral position. So first thing I do, I go through different diaphragmatic breathing exercises because our diaphragm is one of the muscles of our core. So you need to have that proper breath support. So if you put your hands on your low belly, the first thing I would do is have that patient or client take a big inhale into the belly, feeling that diaphragm expand, and then exhale, fogging the mirror with the breath. I'd go through this. I'd change up the hand placement so they could feel that full diaphragm activity. And then I'd also change up the exhale. So instead of doing a mirror fogging exhale, I would do inhaling and exhaling like a snake. So that we can get that deep transverse abdominis engaged. Do about 3 or 4 repetitions of that. And then from there, we'd move into pelvic tilts. So I'd like to use a pelvic triangle placement with the heels of the hands on the pelvic bones and the pointer fingers on the pubic bone. You're going to start then by rocking the pelvis back and forth. I should also say that if someone has severe osteoporosis and I notice that they have a thoracic kyphosis, I would have them start on a Pilates wedge or propped up, because if their spine is fragile and is at risk for fracture, you don't want to put them flat initially. But if the person, after doing the initial evaluation, I see that they can tolerate laying flat, then laying flat would be okay. So after we go through the pelvic tilt position, I let them take one more pelvic tilt, feeling how far they can go down towards their feet, then how far they can go up towards their face, and then tell them to find the middle ground, somewhere in between those two positions, and that is the neutral pelvic position. So now we found neutral pelvis, we want to find neutral spine. So for neutral spine, I like to guide people towards the xiphoid bone. So the xiphoid bone is where the rib halves meet. You want to find that, and then also find the pubic bone, and just let the rib cage soften enough so you feel like they're both on the same level. What that does is that allows the rib cage to line up, and then you will achieve that natural curve. It looks different in everyone's body, so don't judge based on how it looks in mine. So from here, to keep that neutral spine, I would move on to arm arcs. So for arm arcs, it's a simple exercise of hovering the arms, using it and pairing it with the breath, bringing the arms overhead, and then arcing the arms back down. Now we go through this in a few repetitions. And so the challenge here is most people will initially want to go like this to reach the arms overhead and arch their back. And so that is the challenge, is that you are trying to keep that xiphoid pubic bone connection, keeping that neutral spine. Good. Okay. And so once that is achieved, I always like to do that first because that's the more challenging part. I will move on to supine march. So from here, it's a simple of lifting the leg up and then back down. I pair this with the breath. I cue for that deep pelvic floor core engagement, marching. And this again is just to find the neutral spine. As a Pilates rehab specialist, working in neutral spine is the ideal place to start for movement re-education and for learning new movement patterns. Okay, so that would be the series I would start with on the back. And then what I would do next is we would come onto all fours, onto the hands and knees to get some weight bearing into the upper extremities. Also, just to reiterate where neutral spine is on all fours, right? So some people will go into all fours and end up like this. Some people will go into all fours and end up like that. But you really want to be aligned in the spine. There should be the natural curves, the lordotic curve, the thoracic kyphotic curve, and the cervical lordotic curve present. So from here, the first thing I would start with is just shifting the weight forward and back. And then going side to side. Simple shifting the weight forward and back, and then side to side. And then from here, the progression will be to lift the arm up overhead and down, and then the other side, breathing, and then the legs, lifting and lowering, starting with just sliding the leg. And then it would be the opposite arm and leg, but that's a whole progression. And depending on how the patient or client is, we would modify as needed. And before I get into seated, there was one more exercise I wanted to show, which was prone press up. This is where I like to start with thoracic extension education. Granted that the individual doesn't have that severe thoracic kyphosis, right? Because if the thoracic kyphosis is severe, they won't be able to comfortably lay on their stomach. And therefore, I would do the seated version instead, which I'll show you after this. So the palms are going to be down. The spine should be straight. And the goal here is to just move in your mid-back, not your lumbar spine. So I'm going to show you the difference. So I'm going to start pushing through the hands, lifting up just to the bottom rib, and then lowering back down. So this is how much range I would want for that person to be moving properly through their thoracic spine. Now, if they do it and they use their lumbar spine, it would look like this. Okay, but I want them to be really scooping the belly in, pressing the pubic bone into the mat, and then inhaling, gently pushing through the hands, just lifting that upper back. So it's a very small range, but it's allowing for that articulation into extension, which is really what we want to be promoting in osteoporosis. So it's very small, belly lifting, pubic bone pressing down. Okay, so that would be if someone can tolerate laying flat. Now, if they cannot, I would do seated thoracic extension. So let me just make sure you can see me. So seated thoracic extension, you would be sitting in a chair. I would have them likely go up against the back of the chair, feet flat on the ground, arms across the chest. So just think about it. If someone is in a fixed kyphosis, there's a difference between a fixed kyphosis and a non-fixed. If someone is fixed, just sitting up may be a challenge, right? So I would put props behind their back. But if they're already somewhat erect, the next direction would be going actually into the extension. So we're promoting extension. So that is a very quick intro for what I would do with some of the exercises. Now, mind you, everything that I do when I'm working with patients is tailored to them. So there could be a bunch of modifications, but what I'm hoping the take home is for all of you with what we just discussed today is that physical activity can increase your bone density because of Wolf's Law. When you're applying excess stress on the bones, be it weight-bearing activity, resistance training, weight training, things of that nature, you can increase your bone density. Actually, just yesterday, I had a patient who just had her bone scan. It's been a year. And she has better results. So her T-score has gone up and her bone density has increased. We've been doing a ton of agility exercises, resistance exercises. It was progressive. We started very foundational with some of those exercises that I just showed you. And now she's doing very challenging exercises with resistance bands, with weights, and previously with the Pilates equipment as well. So there is power in movement, and movement can heal and help to improve the bone density. Knowing a physical therapist who understands osteoporosis is important, of course, because there are movement contraindications, and you want to have someone who can assess and look at the entire body. So I'm just gonna finish up now if there are any questions. Okay, no questions. All right, so I'm going to finish with the screen share.
No questions? I'm sorry.
What'd you say?
I was impressed by the fact that you said that you can improve.
Yes.
You do all the things you need to do.
Right, right.
Yeah, and you think that what we are doing is towards that?
Yes, yes. Right. So yes, which we can talk about more in a little bit, but yes, definitely. So just want to bring up the rest of the schedule for this month. So the next topic will be pelvic floor dysfunction. That's happening July 17th, 10:30 a.m. if you want to learn about pelvic floor dysfunction. And same thing, just sign up and you'll get the link via email. There are some ongoing classes that we're doing. The Pilates beginner mat class, Tuesday, 11 a.m. that's taught by myself. Virtual Pilates intermediate that's taught by Dr. Amarantha Burkle, Wednesdays at 6 p.m. If you refer a friend, you get one class free. And then I will be announcing this week the virtual workshop schedule. So these are some of the topics. This will be coming out in an email. I'll be speaking about diastasis recti on August 8th, Pilates for desk workers, August 29th, fascia with my colleague Tracy Matthews, and then a pelvic floor workshop. The workshops are much more intensive and in-depth than this, because they're 2 hours, 2.5 hours in length. This is just a little complimentary lecture to my patients and clients. So you all have my contact info, and thank you so much.
Thanks.
All right, if you have any follow-up questions, you all have my contact info. But thank you, and if you want to learn about pelvic floor dysfunction, tune in next time, okay?
See you in half an hour.
Okay, bye.